Good morning, everybody. I hope everyone's refreshed and ready for another packed day of awesome events. So 2 announcements this morning before we get started. One is make sure to meet out here where our food has been around 11:45 before lunch so that we can get a group picture. We want to make sure to get a group picture while everybody's still here. And the second thing I want to do is just give a shout out to our sponsors for this conference who really helped make it possible. So we have one silver level sponsor, Facebook, and then we also had 2 bronze level sponsors, Augie's Heart Tribe. For those of you who know Nicole Spurlock, her son Augie, they donated from their foundation, and also Big Theory Creative. So we're so grateful for their generosity. I hope everybody has a great day, and I'll let Nisha introduce our first speaker this morning.
All right, so when I first heard PCD, it was shortly after I actually heard heterotaxy, and of course I was like, that's my child. I mean, her atypical asthma, her, reactive airways disease, everything she had been diagnosed with, that nobody ever could make sense of, all of a sudden made perfect sense with PCD. And along our journey, we've been able to connect and be part of a research consortium through the Genetic Diseases of Mucociliary Clearance Center, right? Yes, okay. I'm always like, did I get all those right? But anyway, so I met Dr. Shapiro through the PCD Foundation and our work with the GDMCC. He has been phenomenal he truly has an interest in heterotaxy and in PCD and how those play together and overlap. So we are very, very blessed today. Dr. Shapiro was able to travel from Canada and actually gave up time on a family vacation to be here with us. So we are very grateful to have him today, and we'll turn the time over to him.
Thank you guys for having me. I appreciate it. And actually, vacation, I guess it did start today, but they're at my in-laws' house, so I'm happy I'm missing it. That's not recorded, I hope. Thank you. So I want to talk to you today about human cilia. And you've heard a little bit about cilia over the last day, but human cilia are everywhere. They are many different types, which I'm going to talk to you about, but they're everywhere from the eyes and the ears and the base of your brain, into your bones, into your heart, into your kidney, into your liver. And these human cilia are small projections, which I don't know if you can see the pointer, small projections up from the surface of the cell. And they're very, very complex. They can either move or they can either sense. And within the cilia, there's transport going on. There's little particles and things being brought up and going in and out. So it's actually a little assembly and storage area, and they're incredibly complex. And in fact, if you look at the tail of a sperm, they also have the same structure as human cilia, so that's why some of these human ciliary diseases will actually affect fertility. And so what I want to talk to you about first are these primary monociliums, or these are the ones that they talked about yesterday that are in the embryo when you're roughly 3 to 8 weeks of age. And if here's a picture of them whirling, so there's one on each cell, and they like to whirl. And you notice they have this outer structure of 9 doublets, and they have these little hooked dining arms on the inside and outside of them. And what those do is they actually propel fluid from the right side to the left side of the embryo and tell your body how to break symmetry. Because up until this point, you're just a cluster of cells that have just divided 2 by 2 by 2 by 2, and everything's perfectly symmetric. But somehow the body has to decide the heart should go on the left, the liver should go on the right. That's what this does. And it's actually cool because some really cool researchers in Japan realized that, if they're whirling like this, how do they propel fluid? And it's actually that they're tilted and propel fluid like this. And there's 2 theories as to how these work. Some people think that they actually propel little neurovesicular particles, so little kind of suitcases of genetic information from one side to the other to tell the body how to form its sidedness. And there's other people that think these are the motile nodal cilia I'm talking about, and then these are sensory cilia over here that actually sense the flow. And so there might be an overlap between the 2 there. Not terribly important, just kind of interesting. So when these cilia go wrong, you can get organ laterality defects. So situs solitus is what most of the people in the world have. Well, that's where your heart and your stomach are on the left side, and we always reverse left and right in medicine because it's like the patient's facing you, just to make this even more confusing. And then your liver is on the right side, okay? You can have situs inversus totalis, excuse me, where every single organ in your body is a mirror image, but they're all normally formed. And then you can have anything in between. And as you guys know, anything in between can truly mean anything. What we've tried to call this in the respiratory cilia world is a situs ambiguous spectrum, because as I'll go into it, the definitions and the nomenclature are just horrible in this. But you can get anything from isolated dextrocardia, so everything's in a good place except the heart's on the right. You can get the right isomerism we talked about, where you have 2 right lungs, 2 right atria, asplenia. Left isomerism, where you have 2 left lungs, 2 left atria, so you often need a pacemaker, and polysplenia. You can get just the abdomen flipped, or you can get just the thorax flipped. But it can be anything in between. It does not fall anywhere into these nice categories, as I'm sure a lot of you guys know. So when you look at situs inversus totalis and situs ambiguous, and I'm going to use the term situs ambiguous and heterotaxy kind of interchangeably here, so it's pretty rare. It's about 1 in 10,000, okay? And again, they often use this term interchangeably with heterotaxy. But to a cardiologist, what is situs ambiguous or heterotaxy? A very specific collection of incredibly complex heart disease, and there also happens to be something messed up in the abdomen, is usually what they would say. Genetics, to a geneticist, they would say it's a collection of organ laterality defects, doesn't need to necessarily involve the heart. And to a pulmonologist, it's really any organ laterality or cardiac defect that happens with a disease of respiratory cilia called PCD. And the problem is not all cases of situs ambiguous or heterotaxy are caused by cilia issues. There's lots of other ways. You heard about ZIC3, you heard about complex things, but I'm really going to talk about the ciliary type right now. And so the problem is there is no standard definition of situs ambiguous or heterotaxy. And as I was showing you, each medical specialty approaches this differently. But the problem is you have patients that don't fit nicely into the categorization. So yesterday, Dr. Del Nino was talking about the asplenia, polysplenia. That's how their group broke it up. But what do you do if you have a normal spleen, but everything else in your body is scrambled up? Then you don't fall into any nice kind of category. And so that's the problem. There's others that will only approach heterotaxy based on the atrial appendages. So if you look at the 2 atrium, the top vessel chambers of the heart, the right one and the left one are different. The left one has this little finger-like projection coming off called the left atrial appendage. And it's really hard to see even on an ultrasound. It's usually when the chest is open that you can really tell, is it a true morphological left atrium with an atrial appendage finger sticking off or not? And then they will only name the child's laterality based on that. So if you have 2 left atrial appendages, they'll call you left atrial isomerism. And then everything else in your body will be called left atrial isomerism. But you can have polysplenia, asplenia, you can have everything with it. And so that's the big problem here. So if you look in red here, these are all the incredibly complex cardiac defects that no cardiologist would argue with you. Most likely these are heterotaxy defects. Although double outlet right ventricle in isolation without any other organs in the body affected, most cardiologists would not call that heterotaxy. So you can have these in isolation, you can have them with abdominal defects, you can have them anywhere. And then you can have very mild heart defects like a ventricular septal defect, which I know some people in this room, their children have, and that's their only heart defect, but no cardiologist would ever call that a heterotaxic heart defect. But it's kind of hard to blame on something else other than cilia when you've got all of this jumbled up, okay? And then there's a lot of other things that happen, such as biliary atresia, intestinal malrotation. Those things can happen outside of ciliary disease and situs ambiguous, but they often are seen with situs ambiguous as well. So I have a little trivia here. There are famous people in this world with situs problems. So situs means how the organs are placed. So does anyone know who this is? Enrique, good. Okay. I figured someone would know, maybe the back corner. So does Enrique have situs inversus, situs solatus, or situs ambiguous? What do you guys think? Inversus. Yes, good. So he has situs inversus totalis. So I've been talking all about kind of these rotary monocilia on the embryo that form left from right. But now I want to switch a little bit to the respiratory cilia, which is where my interest lies as well. So on the respiratory cilia, they line the entire respiratory tract from the back of the nose all the way down to your air sacs. And they're like the street sweepers of the lung. They beat. Every time you're breathing stuff in, you're breathing in particles of dust, debris, viruses. It sticks in the mucus. And that mucus sits on top of the cilia throughout your lungs. And the cilia are constantly beating really, really quick. And you come up, you swallow about 100 times a day. You don't even realize it's happening. But this is how your lung is maintaining, and your whole respiratory tract is maintaining its cleanliness. And each of these respiratory cilia are incredibly complex. There's over 600 proteins that go into making one of these. That means there's 600 plus genes that make these proteins. So it's a really complex little organ. And if you look at the respiratory cilia, unlike the embryonic cilia I was talking about, the respiratory cilia have 200 cilia on each cell. And they have this 9+2 configuration. So you see the 9 outer doublets there. You've got the central pair. You've got the outer dining arms, the inner dining arms, the radial spokes, and then these things are called necks and links. And these are all the things that can go wrong when you have respiratory cilia dysfunction. You can be missing these structures. So when you watch how a cilia beats, this is normal beating. This is a sample scraped out of someone's nose. You can see it was beating really fast, and then it stopped. But you can see it's even trying to clear a little piece of debris right there. There we go. And so they all kind of beat in unison, and they're happy, and they move stuff over the surface. And these cilia are smart little buggers. They actually have directionality. So you heard the term planar cell polarity. These guys line up so that these latex beads that I've put on top of cilia here, no matter where they are on the screen, they all go down to the lower left-hand corner. So they're smart. They know left from right and back to front. And that's important because you don't want to be transporting mucus this way. You want to be transporting it this way. And so you can see from these latex beads, they're smart. Plus, it's just fun to look at videos. So what we have found, the disease of respiratory cilia that we're interested in is primary ciliary dyskinesia, or PCD, as I'm going to call it. So this is a disease of defective mucus clearance from the upper and lower airways. That street sweeper mechanism isn't working well. And this is from a genetic defect, so it's called primary. Secondary is what I have right now with my wonderful head cold that my children gave me. My cilia are paralyzed by a virus, okay? That's not what we're talking about. We're talking about from a genetic origin, okay? And it used to be called immotile cilia syndrome. That's no longer the case because now we know the cilia move. They just don't move well. They're dyskinetic. It means they kind of dance around in a silly fashion. And you develop chronic ear infections, sinus and nose infections, and lung infections from the mucus that just sits there and gets infected. And so you can see WT means wild type. That's science jargon for normal, okay? And so you can see that this is a normal cilia, and you can see the range that it beats and goes back. It forms like a cup-like kind of saucer and then goes forward, and you can see how that could carry debris. And so if you look at some of the genetic mutations that cause PCD, like Haydn, you can see that the cilia, instead of doing this wonderful back and forth motion, just kind of sit there and go like this. Or then another one, DNH11, they kind of bend like that and just beat at the back. So this is what you see in primary ciliary dyskinesia. And so what happens with this? Well, I've already told you get lots of infections from stagnant mucus, but you really, some of the young kids especially, have severe hearing and language issues because their ears are constantly full. And so until you drain them with ear tubes, they're basically deaf. And where I'm from in Montreal, everyone speaks 3 to 4 languages. And so when they come to me, they say, oh, no, my kid just speaks 3 to 4 languages. That's why none of them are very good. And I say, no, your kid's deaf. And we send them for the audiology, and they are, in fact, deaf. Okay? So you've got to drain that fluid out to allow them to hear. But it also is an extremely poor quality of life. I don't need to tell you guys what poor quality of life in infancy is. You go through horrible heart surgeries and things like that. But imagine going through a bad heart surgery with the worst cold of your life, but you have that every day of your life. And that's what these kids have. They are never well. They don't know what well feels like. And then you put them through a second thing, like a big heart surgery, it may not turn out well. Okay, and then they get ongoing lung damage. So they get chronic inflammation, bronchitis, recurrent pneumonias, and eventually they get something called bronchiectasis. So I don't know if you see these holes in the lung down at the bottom here. That's an irreversible dilatation of the airways called bronchiectasis. And once you have that, it's a spot for more mucus to accumulate and more infections, and it kind of sets off a vicious cycle. So it's something we don't like to see, but it's something very common in this disease. So PCD is an autosomal recessive disease, meaning you need one copy from your mom and one copy from your dad. So if you have 4 kids, if the law of averages plays out, you should have 1 kid that's completely unaffected, 2 kids that are carriers in the half blue, and 1 child that has both bad genes, both mutations, and is affected. And so the rate of PCD is probably about the rate of heterotaxy. It's about 1 in 10,000 up to 1 in 30,000. It's probably more around 1 in 15,000. So that means if you look throughout North America, and I include Mexico and North America, there's 50,000 cases, but less than 1,000 have actually been diagnosed. So there's a lot of people walking around with this. Okay, and in some groups, such as our Amish populations in Great Britain, the Pakistani populations, it's as common as 1 in 2,000 kids. And so that is basically as common as cystic fibrosis, which I know you've all heard of cystic fibrosis. So it gets really, really common. And so it's really not rare. The problem is it's just poorly recognized because it masquerades as daycareitis, okay? These are the snottiest kids in the world, and under age 5, it's really hard to separate them out from just a regular kid that's in daycare. My own kids, I thought, had PCD at some point after their first couple years in daycare. But it also looks just like a lot of the other diseases we see in our respiratory clinic. It looks kind of like cystic fibrosis. It looks like people with immune deficiencies where you can't fight off infections. It looks like bad asthma, and in fact, it's often misdiagnosed as bad asthma. Chronic aspiration, where you might have some neuromuscular delay and the milk is going into your lungs instead of your stomach. So it can look like a lot of other diseases, but it's really daycareitis that is the big throw-off for us. So our Genetic Diseases of Mucociliary Clearance Consortium, I think that was the word you got wrong, but you were close, was established in 2004, I believe, to try and study PCD and figure out more about it. And so we have all these centers that you see here, and it's headed out of UNC at Chapel Hill. And so what we did was we were able, with over 1,000 people that came to see us, either because they thought they had PCD or they'd been told they had PCD by their local institution, we found out that all of the symptoms start early in life, often before 6 months of age, really, not even a year. So this doesn't wait till you're a year and a half of age and then start daycare, which in Canada moms get a full year off, so no one starts daycare before a year. Here it's hard because people start daycare at like 6 weeks. And so yeah, go ahead. We'll do questions at the end, unless it's killing you. Go ahead.
Well, we need a mic because it's being recorded.
Here it comes.
I've always wondered how much our prophylactic antibiotics are hiding these in patients since they start on them at day 1.
So I'll show you, actually. They should still have symptoms even if they're on prophylactic antibiotics. You'll see in a sec. It's actually a very good question, though. So these kids have year-round, daily wet cough, okay, 99% of them. Think about that. Not 2 weeks with a cold, not just in the winter, but they're fine in the summer. Year-round, daily wet cough, almost 100% of them have that, okay? Year-round daily nasal congestion, the same, about 97%. A lot of them have recurrent ear infections and chronic fluid in their ears, and a lot of them have recurrent pneumonia and bronchitis. The reason it's in a green box is so many normal kids that I see in my clinic have recurrent ear infections and pneumonia bronchitis that I'm going to show you. It's actually not a good thing to use to separate out PCD. The neonatal respiratory distress is interesting. For some reason, when these kids are born, the cilia are needed to transition from a fluid-filled lung when you're inside your mom to an air-filled lung out in the world. And for some reason, this doesn't happen very well, and they get trouble breathing. They need often 2 weeks of oxygen in the intensive care unit, despite the fact that they were born on time, not premature, and they have collapse in their lungs. Chronic sinusitis, sinus infections all the time. Bronchiectasis was that dilatation of the airways. And then male infertility, because remember the sperm use cilia to swim as well. That's seen much more often in adults with this disease who can't remember, did I have trouble breathing when I was born or not, because they don't remember because they were babies. But situs inversus totalis or situs ambiguus / heterotaxy are seen in more than 50% of these patients. And so that's kind of how I tie in with you guys. And so there's really 4 key clinical symptoms that'll help you know if you should worry about PCD or not in a child. The first is unexplained, and that's in quotes, neonatal respiratory distress, so trouble breathing, needing oxygen or CPAP or some kind of support for more than 24 hours. The problem is if you have a heart defect it's not so much unexplained. So you can't really use it if you have a major heart defect, but there are mild heart defects that should not cause trouble breathing when you're born. And in those children who also have an organ laterality defect, which is the fourth thing, that might be something to consider. And then the other two things are year-round daily wet cough and year-round nasal congestion, often before 6 months of age. If you have all four of those symptoms, it's 99% specific, meaning you're diagnosed right on the spot. I still have to do some testing, but I know that you've got it right there, okay? Notice what's missing from here. Ear infections is missing because they're so common in the general population. Pneumonia bronchitis is missing because anyone that shows up to an emergency room gets told they have pneumonia often when they don't, okay? And so they don't really help you. So those are the four things. So for people sitting in this room saying, okay, my kid has an organ laterality defect, because everyone's kid here probably has a form of heterotaxy, they need to have these other three things, or at least one other thing, to really be considered, do I need to think about PCD in my child with an organ that is misplaced? Okay? So I've got some other famous people. Did you get to guess the starsitis? Does anyone know who these people are? I'm looking for gray hair, because this is an older one. So Sean Connery and Dr. No. So Sean Connery is cytosologist, but Dr. No is situs inversus totalis. He gets shot in the chest in one of the books, but since his heart's on the other side, he survives, and he comes back to try and kill James Bond in the next episode. So there you go. So why do people with PCD and situs ambiguous, why does it occur together in some of these people? I've shown you the cilia and stuff, so why does it actually happen? So if you actually go back to the cilia, you can see that the embryonic cilia have these dining arms, right? And if you're missing a protein in one of these dining arms, then you might not whirl correctly and you might not make your form your left from right correctly. And then if you're missing that same protein in the respiratory cilia, then they might not beat correctly and you might have PCD. And so that's really why. But if you notice, there's no central pair in the embryonic cilia, and there's no radial spokes. So what that means is you don't need those things for this to function correctly. So there are a lot of people that get PCD through problems in radial spokes or central apparatus. They don't have heterotaxy or organ laterality defects because their embryonic nodal cilia don't need those parts to function. So it's just kind of cool. Anyway, so when I say, okay, I think your kid has PCD, but I actually want to try and definitively diagnose it, the problem becomes there is no single test that can actually detect all forms of PCD. So you can measure nasal nitric oxide, which is a colorless, odorless gas that comes out of the nose, and you measure with a special machine, but you really can't do that before 5 years of age. You can do it down to 2, but it's not as robust. You can scrape some cilia out of the nose and look at them under an electron microscope and look and see. Here you can see there's that hooked outer dining arm is missing. So you can look for something like that, but guess what? 30% of PCD can have normal electron microscopy. You can do high-speed video microscopy where you take them out of the nose and you watch the cilia beat, and they love doing this in Europe. But the problem is if someone has a cold like me, even if they swear they don't, the cilia are going to beat funny and you're going to give them a false diagnosis. You can do genetics, but we don't know every gene that causes this, and so you can't rule it out with genetics. You could rule it in if you find 2 mutations, but you can't rule it out. So I just want to take you through a little of this, how we do this, because some of you guys have probably been through this already or may go through this after I finish talking. But basically, we're scraping and we're looking at the cilia. And this is a normal cilia. There's the 9 outer doublets, the central pair. You have this hooked little outer dining arm that looks like a comma, very easy to see. And the inner dining arms are here, here, here. They're harder to see, but they're there. Here's an example where you're missing that outer comma, the hooked outer dining arm. Here's an example where they're missing both. You have a stub of a little outer dining arm there, but you don't have the big hook like this. And here's somewhere everything's all jumbled up. Okay? And we thought we knew what we were doing, but it turns out that you don't see changes like this in every patient. 30% can be completely normal. And the problem is we have so many university centers across North America that think they know what they're doing here, that they'll scrape your nose and they'll do an electron microscopy and they won't do it correctly. They'll take a picture of 1 or 2 cilia, not the 50 that you need. They won't process it correctly. They'll do it when you're sick. And this leads to a lot of false positive and false negative diagnoses. In fact, one very prestigious center in the Northeast, when they do this cilia biopsy, they can only get it to work 60% of the time. not actually be able to make a diagnosis from it, but get usable cilia to actually make it work. And these cost you guys about $1,000 a piece, so they're not exactly cheap. So it's something that is a great test in the hands of a real expert center, but the problem is very prestigious centers in this country think they're expert centers, and they're not, okay? And so even with the best center doing this as well as it can be done, you're still going to miss 30% of these. So what else can we do? Well, we have nasal nitric oxide testing. So if this gas that comes out of your nose, nitric oxide, it's colorless, it's odorless, but for some reason it's very, very low in PCD, often in the single digits, whereas a normal person will have levels of 2 to 3 to 400. And we have no idea why. No one knows why, but it's really, really a good test because it's non-invasive, it's rapid, it takes about 10 minutes. It's not expensive to the patients. The machine costs $50,000 for the hospital, but not expensive to the patients, and the results are immediate. So here you can see one of our old research fellows. You put a little sponge in your nose, no deeper than a finger. I always show the kids, look, it's no worse than picking your nose, and you blow into a little party favor or resistor because you want to close off your airway because you don't want to dilute with air from here. You only want what's kind of being sucked out of the sinuses, but you really need to be 5 years of age. So if you look here, here's a study with a bunch of healthy controls where the values were about 3 to 400, and you can see all the PCDs here were well below about 100. The only disease that overlapped was cystic fibrosis. But any child with recurrent pneumonias, bronchitis, horrible nasal congestion needs a sweat test anyway to make sure they don't have cystic fibrosis. We don't know if it can be low in other things. Could it be low in immune deficiency too? There's some recent evidence to show it is not low in immune deficiency. So this is a pretty good test. And so what we did through our research consortium was using a lot of different patient samples, we made a cutoff of 77 nanoliters per minute. And if we put that in your nose and your value is below 77, then it's very consistent with PCD. And if your value is above 77, it means PCD is very unlikely. Not impossible, but very unlikely. And then we used that 77 cutoff at 6 different centers throughout North America, and it picked up all except one case. Okay, so that's pretty darn good right there. Sensitivity and specificity are near 100%. So that means this is an accurate test, and it finds these kids. So what are the problems with it? You can't use it at all below 2 years of age. You can't use it when a patient has a cold like me because it artificially decreases it. So you got to take the snottiest 3-year-old in the world and find them when they don't have a cold. It can be really hard. So I often say, come back and see me in July, when there's not a lot of colds around, and we'll see what we can do then. It can be low in cystic fibrosis, but it might be low in other weird and wild diseases we don't know about. And there's at least 2 different PCD genes where it can be normal. Okay, and we're going to find more where it can be normal. The last problem is these nasal nitric oxide devices are not FDA approved. So you have to travel to a PCD specialty center, which we have in our network, and you have to get it done through a research process. And it's hard to travel sometimes for everyone because these aren't near everyone. So what about genetics? Because why can't we just do a gene test? That would make it easier. And the problem is, again, the genetics are exploding in this. So when I started in 2007, there were only 9 PCD genes, and now there's 43. And so if you compare this to the cystic fibrosis gene, which was kind of the first gene ever discovered as the cause of a disease, a single gene disease, and it's taken us about 40 years to understand it and billions of dollars of research to understand these little changes that happen here and there, are those disease causing or not. And that's a really small gene. If you look, there's only 27 coding regions you have to read through. Now look at all the PCD genes we have to read through. We don't have billions of dollars and 40 years of research on those, and so that's the problem. But we do have commercial genetic testing available where a lot of these gene companies have picked up the slack for us, and they'll test usually 35 or more genes, and it's getting very cheap. There's one company in San Francisco that'll do it for $250 cash price, which is pretty darn good. And this usually includes cystic fibrosis testing as well, which is a good thing to make sure you don't have because the two can masquerade. So if you look at all the different genes according to the defects they have, it makes it easier to group them. So these are all the genes that cause outer dining arm defects, where you're missing that outer hook that you should have. These genes cause oligocilia, meaning you can make one cilia per cell, but you can't multiply it to the 200. So I keep scraping this poor child's nose every time they see me, and we're not seeing any cilia. You can't even find that one. And we now know there's genes that actually cause that. There's a few syndromic forms, which are very, very rare, but actually can occur with a form of blindness. There's a few, these all cause absence of the outer and inner dining arms. You can see these little doublets look kind of naked. These guys cause microtubular defects, where everything's just kind of disorganized. And then these guys all result in a normal electron microscopy. And all of these in blue are the ones that actually cause heterotaxy. So you can see all of these normal EM1s that affect the parts of the cilia that aren't needed for the embryo cilia to work. Those don't cause any laterality defects, but all of these guys too. So actually, if I have a patient with heterotaxy, I have a much higher chance of picking up their disease on electron microscopy, because all of the ones in blue are pretty easy to see on electron microscopy. These are the guys that will be normal, and there's only one that can cause heterotaxy that would be in that group. So that's good news. But what are the problems with genetics? So first, we haven't discovered all the genes that can cause this. Not every change in a gene is pathogenic or disease-causing. We all have different genes from each other. That's why some of us have dark hair and some of us have light hair. That's a change in our DNA. But you've got to make sure that's a change that causes disease, and that's the problem. And we only look at part of the genome. So we only look at something called the exome. That's about 1 to 3% of all of your genes. The rest of the genes is stuff called the introns. It's clipped out, and we think it has nothing to do. It's just extra. It's garbage. But the problem is you probably have a lot of disease controlling things in there too, and we're just not smart enough to look at it yet. And then certain test methods, like these gene panels that we all get done commercially, will miss large changes. So I think of it this way, and no one under age 30 understands this anymore in encyclopedia, but if you have an encyclopedia here, and I pull out volume 6 and just squish it together, if you read through it real quick, you might not realize volume 6 is missing, because it's a big piece that's been taken out, and that's what some of these gene panels will miss as well. So you have to make sure that you're getting it with a good company and the right company that knows to look for those types of changes. All right, so this is a local Utah boy. Does anyone know if he has situs solitus, situs inversus, or situs ambiguus? Situs inversus. He almost died of a ruptured appendix because it was on his left, actually. Yeah, many years ago, but yeah. So what is the rate of situs ambiguus in people with PCD? So if I take a bunch of people with PCD in my clinics and I look at all their organs, how many of them have an organ that's misplaced? So at first we knew this was about 6.3% from a retrospective study. So this was Dr. Kennedy at UNC, where I trained, who went and got databases from all over the world, from Europe, from Australia, and looked back at their data. And if they hadn't scanned the abdomen, well, then you didn't know about that patient. But if they had, then you'd know, okay, this guy has polysplenia. And he showed that it was about 6.3% of PCD patients have situs ambiguus. And so I wanted to embark on this a little further in my fellowship and said, let's do this prospectively. As these people come to us, I want to talk to them, I want to examine them, I want to look at all their imaging, whatever they have available, and try and see, because we think it's higher than 6.3%. And so the problem is, then we get into the definitions. What do you call heterotaxy and what do you don't? And so we kind of split it out into those that would have definite heterotaxy that Dr. Del Nino would never argue about, and then those that had a heart defect but not a complex one, but their abdomen had lots of issues, and then some of those that just had abdominal issues but nothing in the heart, and then some that just had one organ affected, like just polysplenia or just an aortic arch on the right side and not the left side, something like that. And so what we did was we had 760 people come, and we were able to diagnose PCD in about 300 of them definitively by electron microscopy or genes. And what we saw was about 12% had situs ambiguus. And the reason is they looked like situs inversus totalis on a chest x-ray. But when you look closer up their abdominal ultrasounds and things like that, you'd find polysplenia or an interrupted inferior vena cava or things like that. And what we found was there were those that had complex heterotaxy, really bad hearts, really scrambled abdomens, some that had just a ventricular septal defect, so nothing that a self-respecting cardiologist would ever call heterotaxy, but they had a lot of stuff below the diaphragm. There was actually the most had just abdominal issues, not heart issues. That probably represents a survivor bias because people with really bad hearts may not have lived long enough to come to our study. But we had a lot of people who had PCD with just an isolated laterality defect. nothing that anyone would call heterotaxy. And we compared these against what we called our situs ambiguous controls. So people that came to our study with heterotaxy or situs ambiguous, but ultimately did not have PCD after we did all the testing, because we wanted to see what's the difference between these people clinically. And so we had various causes of PCD with situs ambiguous. Back then, we only knew about 10 genes or 12 genes, and 9 of the genes were represented. And again, there were none of those radial spoke or central apparatus defects, which makes sense. There shouldn't be in heterotaxy patients. But what we saw was even if you had severe heterotaxy, something we call mild heterotaxy, or even just a laterality defect, you still had very low levels of nasal nitric oxide. So this wasn't like a spectrum where you were worse as your organs were worse. You all had the same disease regardless, okay? And it was very low, 12 versus 252 in those situs ambiguous controls that did not have PCD. And if we look at all the symptoms, you see that, okay, they have a lot more year-round wet cough and a lot more year-round nasal congestion, and that's what you expect. But we have these very interesting symptoms. So digital clubbing, I don't know if any of you know what it is. It's a kind of a rounding of the nail bed that you see in lung diseases, but also in congenital heart diseases, especially ones where you're cyanotic, where you're blue. But what was interesting is only patients with PCD and situs ambiguous actually had this. None of the 22 patients that had really bad heart defects and situs ambiguous but did not have PCD, none of them had that, which was curious because we would have expected some heart kids, bad heart kids, to have that, and they didn't. The other thing we noticed was the amount of trouble breathing when you were born. It was, of course, higher in the PCD group, but we said, oh, well, it's not a fair comparison because so many of these kids have bad hearts. That's why they can't breathe. But remember, some of these kids did not have hearts that were that bad. And a lot of them had heart lesions that would not typically make you breathe heavy in the newborn period. And if you see, there were actually more heart lesions known to cause trouble in the newborn period, but there was less trouble in the newborn period. So you can still use the neonatal respiratory distress as a marker of PCD, especially in a kid with situs ambiguous that doesn't have a severe heart defect. What I was hoping is we'd be able to say, only kids with left isomerism have PCD, there's a real connection, and those are the ones we have to worry about. But it didn't work that way. It was any organ laterality defect anywhere. And what we also saw was that nice categorization of asplenia, polysplenia does not work at all when you're trying to study these people. So I've got up here in the gray the normal, where they should normally be. So the heart should be on the left, the stomach should be, or the liver should be on the right. These first two have what looks like situs inversus totalis on a chest x-ray, because everything's flipped, because you can see it's right instead of left. But when you look closely, they have polysplenia, and one of them has bilateral SVC. And that's their only defect. And no self-respecting heart surgeon or cardiologist or even geneticist might really call that heterotaxy, but we think it is. This other guy just had 2 left lungs and a polysplenia. This guy, actually, his heart was on the correct side, but just his abdomen was flipped, and he had a VSD, a hole in his ventricles, and malrotation. And these guys were completely normal on an X-ray. Their heart and their stomach were on the left, and the liver was on the what looked like the right, but it was middle, but they have an interrupted IVC. And this guy was the most fascinating because he's completely normal from an organ situs standpoint, but he had tetralogy of Fallot. And tetralogy of Fallot is not something that a cardiologist would generally consider to be a ciliary defect in the heart, but we actually think it is. So there were no specific defects that you can see that should make you think, oh, this is more likely PCD. And we had a lot of mild kids that wouldn't fit into the classic categorization. Okay. So what about this guy? Does anyone know this guy? So Sean White, do you know what his situs is? Yeah. So he's kind of the poster child. So tetralogy of Fallot. I think he was probably a very mild tetralogy of Fallot, but he was.
Well, I knew that, but I didn't know the left.
Sorry, yeah, so he's tetralogy of Fallot, but here's the thing. Again, a cardiologist will say, well, that's not a cilia-related heart disease. Well, it turns out it is. So if you take mice and you knock out the genes that cause PCD in those mice, it's called DNAH5, you get about a quarter with situs solitis, you get about 2/3 with, or 35% with situs inversus, and you get 40% with situs ambiguous or heterotaxy. But the only thing some of those mice have is tetralogy of Fallot. So it's hard to say tetralogy of Fallot is not a cilia disease. It is a cilia disease in a mouse model, and we have to change the way we think about categorizing these things. Okay, one more. Anyone know this guy? Oh, you know this guy. Come on. So Brett Michaels, right? He has a VSD. So technically, if you're using the categorization we'd use in someone with PCD with a VSD, that would fall into situs ambiguous. So does having situs ambiguous and PCD make you worse, right? You have two diseases. It would make sense to, it might make you worse. And so we looked at a bunch of kids in our data sets, and we compared those that had situs ambiguous in PCD to those that just had normal organ arrangement or complete situs inversus totalis. And it turns out the kids with situs ambiguous and PCD are worse in the long run. They have worse nutrition. They have more bronchiectasis, so that non-reversible scarring on the CT scans of their chest, and they have more bronchitis and pneumonias requiring IV therapy. And this even held true in people that did not have heart disease, but just had maybe their abdomen affected. Is that due to the asplenia and the immune dysfunction? It's hard to say, but I think it needs more study. The other thing that was striking about this is kids with situs ambiguous are diagnosed significantly later, 6 years of age, versus those with situs solitus or situs inversus are at 3. So the big question comes up, you're hiding in a cardiology clinic for the first 6 years of life. Why is your cardiologist not thinking about this? I mean, you're having year-round daily wet cough and year-round daily nasal congestion from birth. That's not normal. But I think they're probably just being fooled into thinking this is daycareitis and you'll get better with age. But we don't know. So we know how many people with PCD have situs ambiguous. What if we flip that around? How many people in this room or in a cardiology clinic with situs ambiguous actually have PCD? That's the million-dollar question here, right? How many heterotaxy kids have PCD? So it's hard to do that. It's hard to get into a big bunch of cardiology clinics and test every kid. But what we did was we worked with another parent advocacy group called the Heterotaxy Hope Organization, and we sent them a very, very big, very lengthy survey to complete, asking about symptoms of PCD, such as respiratory symptoms, bronchiectasis, which is that irreversible scarring, how their organs are situated, past cultures of their mucus, their airway mucus, to see if they grew bugs that were funny, which shouldn't be grown except in PCD, and then past testing of PCD or cystic fibrosis, as someone actually thought about this in them. And so we defined those that we thought might have possible PCD as having 2 or more of these chronic respiratory symptoms, or bronchiectasis on a CT scan, or past respiratory cultures with these bugs that are really hard to say, but should not be ever found in a normal airway, okay? And we had 49 people respond, and most of them were parents of patients greater than a year of age. 98% of them had major cardiac defects, so they were very much aligned with what you guys have in your group. And we found that 37% of them had symptoms suggestive of PCD. So of the 18, 17 had more than two or more respiratory symptoms. 2 of them had cultures of the respiratory tract, one growing Pseudomonas, and one growing a cousin to tuberculosis, which should not be in your airways. Only 1 of 18 actually had bronchiectasis, but these were young people, and no one had probably thought about scanning their chest yet. But the real shocker was only 4 of them had even heard of PCD and had been told about testing or had previous testing. And so that to me is the shocker here, that no one is thinking of this outside of the respiratory groups. So we invited 4 of these to come and actually see us, and we were able to prove PCD in 1, and PCD was highly likely in another 2. All right, so these are Canadian actors. Does anyone know them? So this is Eugene Levy and Catherine O'Hara. I don't know if you've seen their shows. So situs solitus, but Catherine O'Hara has situs inversus totalis. Yes. So then someone said, okay, there's evidence that some of these situs ambiguous patients might have PCD, and there's evidence it might be a lot of them. So let's look at them. So they actually took some cilia out of the nose of kids with situs ambiguous, and they tested their nasal nitric oxide and did electron microscopy, and they did PCD genetic testing in these kids. And what they found was a lot of these kids have ciliary dysfunction. So if you see down here in these little kind of cartoon things, this is the normal cilia beat, and if you had a decreased amplitude or everything just wasn't beating nicely, they called that ciliary dysfunction. And they compared this to to healthy people and people with known PCD. And so if you look, they split up their heterotaxy patients into those with only heart defects, and about 25% of them had cilia that beat funny. And then they split it up here into people that had heart and abdominal defects, and about 60% of them had cilia that beat funny. The problem is cilia that beat funny is a very, very subjective test. I can take cilia out of my nose, and if I don't put them in the right medium to keep them alive, they start to die. And when they start to die, the beat gets funny. Oh, and again, I have a bad cold today, so if you look at my cilia, they're going to beat funny. So saying, oh, they beat funny is, it's quite a jump to say they beat funny, but this person has ciliary dysfunction. So we have to take this with a grain of salt, this study. But what they did show was that nasal nitric oxide levels were much lower when there was cilia dysfunction. Not surprising again, because I told you if you have a cold, your nasal nitric oxide can be low. So, but what they see is those with PCD had incredibly low levels. Healthy controls had levels near 300. Those heterotaxy did not have any cilia dysfunction. Their nasal NO was pretty good. And then those that had dysfunction, the nasal NO was kind of in an intermediate range. So it's interesting, but it's not definitive proof that kids with situs ambiguous have cilia dysfunction. Most of these kids were lacking those 4 key clinical features of year-round daily cough and nasal congestion. All of their electron microscopies were not diagnostic. There wasn't one in the group that had PCD. But many of them had single mutations in the gene. So remember I told you have to have 2 mutations in the same gene to get this disease? Well, many of these guys had 1 mutation in this gene, 1 mutation in this gene, 1 mutation in this gene. And so how many of those single mutations can start to cause abnormal cilia function? We just don't know. So there may be a case that all patients with situs ambiguous, or a certain group of patients with situs ambiguous, they don't have classic PCD, but they might have something in between. And I know you've all heard about that and talked about that. We're just not smart enough to know anything about it yet. There was another study where they actually took kids with heterotaxy type heart disease, and they used this RAX-1 score, which is a scoring of severity of heart disease, and they matched them against kids without heterotaxy disease, say tetralogy of Fallot, which I've told you could be heterotaxy disease, but they say it's not. And they showed that the people with heterotaxy disease had much worse outcomes. They had a higher risk, 2.7 times the risk of post-surgical death, of needing ECMO, of needing tracheostomy. So there is something to be said that these kids are more fragile, but all you guys know this. And again, we've got the spleen issue and all these other complex issues that may be playing into this that you just can't control for when you're doing retrospective studies, when you're looking back at data. You've got to do this at the time of the heart surgery, enroll them and study them. So this is another guy. Any NBA fans here? This is Randy Foye. He played for the Clippers for a while. He has situs inversus totalis, so you can be a pro athlete. So I've been putting you all to sleep with respiratory cilia and embryonic cilia, and I want to start talking about these sensory cilia. This is what Dr. Ware talked about yesterday. These are found all over the body: eyes, ears, bones, kidney, liver, and they're basically antennae that stick out to the exterior world and sense things. So this is an example of the polycystin 1, polycystin 2 channel in the kidney. So these stick up off every cell in the kidney, and when urine flows by them inside the kidney, it bends them. And when it bends them, you set off a second messenger, all these different calcium things influx through the channel, and you get normal kidneys. And if this doesn't work, you get polycystic kidneys. And in fact, if you start looking at all of these different ciliopathies, these things caused by non-motile cilia, and they're all in blue here, they affect the eyes, nose, ears. You get a lot of obesity, skeletal anomalies, but the kidney and the liver, especially the kidney, are almost always affected by these. And they're very rare. If you go to a big children's hospital, they'll probably have 5 or 6 of these kids maybe seen in one clinic, and that's it. But if you start to put all of these together, they're not that rare. And the big question is heterotaxy syndrome one of these? Because people really don't know. So how many people out there with sensory ciliopathies, so these antennae that stick up, also have lung issues? That's the big question. So we know that you can actually have PCD and a sensory ciliopathy in the eye through the same gene. It's called retinitis pigmentosa, through the RPGR gene. And there's another one that can cause orofacial digital syndrome with PCD. So we know one gene can cause a sensory cilia problem and a respiratory cilia problem. But other than that, it's really limited to case reports, which I've listed out there in case you're interested. But there's no definitive thing to say every kid with polycystic kidney disease actually has a lung problem. But if you start to look closely at this, this was a kid with a very exotic ciliopathy called cranioectodermal dysplasia through this WDR35 gene. And this kid had low nasal nitric oxide and abnormal respiratory cilia, but he didn't actually fit PCD when you looked at him clinically. And so you can see this is a normal biopsy. You see all the nice hairy cilia kind of sitting there. And this is this child's biopsy. There's just one little tuft of cilia there, one there. It's a little funny looking. And then they regrew them in air-liquid interface. So what that means is if you have an acute cold at the time they take this and you regrow it in a lab for 6 weeks, the cells, that cold shouldn't be a problem anymore. And when they regrew it, what they found was there were cilia all over the place, and then this kid only had tufts of cilia. Was that a problem with the regrowth? We don't really know, but it's interesting. Or is that his sensory ciliopathy causing his respiratory issues? And then they took a mouse, and they knocked out this gene in the mouse. And when they knocked out the gene, they got this tuft-like abnormal cilia. And so it starts to get a little more interesting. Maybe there is some respiratory cilia issues from these sensory ciliopathies. And then they started to look at adults with what we call autosomal dominant polycystic kidney disease. So that's a sensory ciliopathy that gives you big cystic kidneys and renal failure, kidney failure when you're older. And they showed that these people had much higher rates of bronchiectasis. Remember that irreversible airway scarring that I talked about? And they said, well, why do these people have extra bronchiectasis? And they took their respiratory cilia and they looked for this polycystin channel, which is a urine channel. It shouldn't be in the lung. And guess what? It's in the lung. There it is. So your respiratory cilia have channels that should sense urine flow on them. Why? We don't know. But you start to see that maybe there's an overlap between all these cilia people and the kidneys, and maybe they have some lung issues as well. So this is the last guess the star situs. Does anyone know Honey Boo Boo? So Honey Boo Boo's dad, Mike Sugar Bear Johnson, actually has situs inversus totalis. I believe in one episode he goes to the hospital and he gets told his heart's on the wrong side. So there you go. All right, so the last thing, and I'm almost done because I see sleepy faces out there. There are actually non-motile sensory cilia in the heart as well. Okay, so I'm not talking about the embryonic cilia that are spinning and telling you how to form your left from right. If you take mice and you cut open their hearts when their little embryos are forming, you find cilia in them. You can see them here. And they're usually only there at one point in heart tube development, but they can persist until much later. And they're actually critical for normal development. If you actually knock them out or do genetic things to them, you start to get ventricular septal defects. Okay, so they're important for heart formation. And when you take a bunch of people with just congenital heart disease, not situs ambiguous, just regular congenital heart disease, or you take mice, and you look for all the genes related to heart disease, they have 61 different genes that you can find related to the heart disease, and 50% of them are cilia related. And a lot of those may be related to the actual sensory cilia in the heart. But if you look, most of these mutations also occur in respiratory cilia as well. And so the big question is, forgetting just situs ambiguous, what about all congenital heart disease? Could all congenital heart disease have respiratory cilia dysfunction? Could they have a ciliopathy? And so the same group that looked at it in situs ambiguous looked at it in just kids with congenital heart disease and not necessarily situs ambiguous. And they did the same thing, ciliary microscopy, video microscopy, nasal NO levels. So they had about 40 with heterotaxy, but they had about 177 with non-heterotaxy heart defects. And they had abnormal ciliary motion in about 50% of those. And if you start to look at those that had abnormal motion and those that had low NO, about 30% had both of those, okay, in the heterotaxy group, but about 20% had that in the people with just regular old congenital heart disease. And if you start to look at their nasal nitric oxide, you start to see an increase in symptoms as their nasal nitric oxide gets lower. So it might not be an all or nothing thing, like you have PCD or you don't have PCD. It might be every kid out there with congenital heart disease, situs ambiguous, has some degree of ciliary dysfunction. This is wrought with errors. This is all scientific curiosity right now, but we really need to study it to show, because frankly, the heart surgeons have done wonderful jobs making your kids better, but their heart surgeries, they've done the big things they can do now. It's not like you're going to get better at doing these major heart surgeries. You'll have incremental increases, but if you can show many of these kids also have a lung disease, and before they're Fontan, they need 2 weeks in the hospital with IV antibiotics and really good pulmonary toilet to get their lungs clean, that may really affect kids' outcomes more than anything else. So in conclusions, we know that both motile and non-motile cilia can affect heart formation and congenital heart disease, but the overlap remains very unclear between these types of diseases in humans. Some people with situs ambiguus have PCD, but mild forms of situs ambiguus, and even congenital heart disease alone may actually have some respiratory cilia dysfunction. So doctors need to think about this. It should not just be the lung doctors thinking about this. If you're caring for situs ambiguous patients, you need to ask those 4 key questions, and when you get 2 of them that are positive, you need to either do the PCD workup yourself or send them to a PCD center of excellence that knows what they're doing. So this is our GDMCC. Used to be headed by Mike Knowles, but he is, I don't think he'll ever retire, but he's slowing down. Some of you might have seen him through research. We have sites all over North America, which you can see. So if any of you are thinking, oh, I need to get to a site to have my kid tested, we can help with that. Michelle Mannion at the PCD Foundation, who is Nisha Monroe, her twin, but it's been doing this longer, I guess, is a wonderful, wonderful resource for PCD. She will talk with you on email. She'll send you to the right places, whatever you need. I'll do the same. But Stephanie Davis at UNC is now heading this consortium. So we've got another 5 years of research ahead of us. So thank you. That's all.
All right, what questions do we have for Dr. Shapiro?
I put you all to sleep. This is complex stuff. This
Wake
is
up.
not easy stuff.
So first of all, thank you. I appreciate the talk. And one of the things is I actually took several notes, but every time I was writing down a question, you actually answered it within 10 to 20 seconds.
Cool, okay.
So thank you. That's really informative that it's not often that I can, I'm like, okay, well, I want to know about this. And then you answered my question. My one question does come from, obviously we have a path forward with PCD itself and heterotaxy. But I would say, there is, and you showed as well, that there's a strong correlation between ciliary dysfunction and our children with heterotaxy. Yeah. What paths do you think we should be taking? Because there's not really a clearly defined, it's like all atypical, and we're kind of managing between multiple specialties who, and I guess the thing is it's more likely that it's all related than it's just a whole bunch of mess strewn across the floor. So what do you recommend that we do, and how can we help manage these kids?
So that's actually a great question. And I agree with you that it's lightning strikes twice sometimes, but it's rare that it really does that. So I do think it's all related. And I think it's going to be spectrum. Some people in this room will have no issues with this, and others will have a lot of issues. So the things we do for PCD is we do a lot of what's called airway clearance. It's just like if you have a big infected abscess on your arm, you need to get that infection out. You can't just give antibiotics. You need to go in and drain it out. So it's the same thing with the lungs. Day by day, you have to cough up this mucus and cough it out. And it's a harmless intervention to get a child that's old enough to blow into a device or to do clapping, or as they do in the U.S. a lot, the vest, although the vest is very expensive. There's other ways to do it that we actually do in Canada. But something like that, I think, is very do no harm. So if your child has a cold, and you know that every time he has a cold, it's going to be prolonged to 28 days, and you're going to need 2 courses of antibiotics, your options are give antibiotics early, or which can have side effects and create resistance and select things out and cause diarrhea and all sorts of things like that. Or you can start doing things like airway clearance as needed when the children are sick. So I think the respirologist and the pulmonologist and respiratory therapists become very important. I have a lot of patients where I'm like, look, I don't know what you've got, but you clearly don't handle viruses as well as the next kid. You probably have an underlying cilia disorder. So when you're sick, I'm going to give you clapping or blow into something to get this out. I even have some kids that'll do inhaled hypertonic saline. So it's an inhaled concentrated salt water that we use in cystic fibrosis and in PCD, and it actually promotes cough and helps liquefy secretions. And if they don't have bad asthma, because it can provoke asthma, we'll try something like that, but maybe just for 7 days around a cold. And if that keeps you out of the hospital or keeps you off antibiotics, it's well worth it. So we can do no harm therapies like that. I also have some children where I'll have them on prophylactic antibiotics for the winter. This gets complete. This is not with the splenic issues, but just Monday, Wednesday, Friday azithromycin. And that's been shown in forms of bronchiectasis to be actually quite helpful in adults. It decreases the number of antibiotics needed urgently. It decreases the amount of mucus, and it decreases their number of hospitalizations.
So we've been very fortunate that our pulmonologist is very, you guys could have conversations about this sort of prophylactic, do no harm treatment. But I know for others that it's not as easy. Do you recommend still getting to a PCD center? And do you think those pulmonologists are going to be more geared and more able to help them on this path than...
Yeah, absolutely.
Okay.
So what I didn't show you is we now have PCD Foundation clinical centers. So in addition to our 9 research centers, we have almost 20 clinical centers. We have one in Boston, we have one in Michigan, I'm trying to think, we'll have one in Memphis soon. So we've got one in Tennessee and Vanderbilt. So we've got a lot of them kind of throughout the United States, and those guys are good too. So they are docs that are very used to treating cystic fibrosis, and they take a lot of what they learn from cystic fibrosis and put it into these children where I can't make a diagnosis, but there's clearly something going on. So, and what they can do is they can help guide your local pulmonologist as well. So a lot of these kids will come see me once a year and then go back to their local pulmonologist, and I write a nice letter saying, look, here's the things I think we can try this winter if we're having trouble. Sometimes it works, sometimes it doesn't. But there's a lot of us that we learn everything we need to learn in the first 5 years out of our residency training, and then we never learn anything again. So we always need to be forced to be educated. And so there's a very nice document that helps with this, our PCD Foundation Clinical Consensus Guidelines, that list out in a very scientific and rigorous fashion all these do no harm cares. And I hand it to patients and I say, give this to your doctor, and I'm going to write in the letter to your doctor, they will be giving this to you, and this is how we think these kids should be treated.
Where can we find that?
So it's on open access. It's in pediatric pulmonology. If you just write PCD Foundation Consensus Guidelines. The problem is not all of your children have PCD. They might be in this intermediate area. But a good doctor should be willing to listen to you and say, there's some evidence here. You feel free to take this talk I showed them and say, look, there's some evidence that these kids are not exactly normal, and my kid suffers. So what can we do, some no-harm therapies to try and make this better? The only thing you'll lose with clapping and hypertonic saline is time, really. That's it. Yeah. And you have to make sure you sterilize your hypertonic saline nebules very well because you don't want to introduce bacteria. That's the other thing.
Any other questions for Dr. Shapiro?
I wasn't going to ask you this, but you did bring it up a lot. What is the difference between polysplenia and accessory spleens?
Yeah, it's a great question, actually. The radiologists see a little extra splenule all the time. These guys are reading 100 ultrasounds a day. There are very normal people without heterotaxy walking around that have one extra little splenule. That does not equal polysplenia to them. If I have a kid with PCD with one extra splenule, it's interesting, probably polysplenia, but I think the official definition of polysplenia is one large spleen with at least 2 accessories, I believe. But again, if everything else fits ciliopathy and I only have one splenule, potato, I want to know if it works. That's the key. So how do I show that spleen works to avoid overwhelming sepsis and things like that? Sepsis is a blood infection, like blood poisoning, as my grandma used to call it. You really need to do what's called a Howell Jolly body. See, it's a very easy test. They take a little blood, they smear it on a slide, and your hematologist or blood doctor looks at it to see if you have something called Howell Jolly bodies. And if those are there, that means the spleen is not functional and you are at risk for severe sepsis. The good news is most polysplenias, I know there's exceptions, are functional. But then I know someone in this room told me a story about how their child clotted off all their arteries to there and it became non-functional. So in the PCD world, even though I actually am very kind of pro for checking this because it's a very minimal test that you can use to maybe save someone's life, it's not officially across the board recommended that you check for Howell Jolly bodies. That may change.
You said some interesting things yesterday to me when we were just randomly talking. A lot of our parents here in the U.S., we focus on the vest, but can you do
Yeah.
You brought up the aerobica and the acapella yesterday. Can you do a quick little spiel on how you feel that's beneficial?
So I trained in the U.S. I trained in North Carolina, and every single person gets a vest. $20,000, you get a vest. And the best airway clearance is what you will actually do and do correctly. For some people, that is the vest. Then I moved to Canada. We're a more or less socialized healthcare system, so why would we spend $20,000 on a vest when there's handheld devices such as PEP, aerobica, acapella, but really PEP is the one that costs $12, and even in a head-to-head study with the vest has been shown superior. So they did a randomized study where they took kids with cystic fibrosis, and they either put them on the vest or PEP, and the kids on the vest all had exacerbations needing antibiotics much sooner than the kids on PEP. Part of the vest is you can just sit there and watch TV, and it shakes stuff loose from the wall, but if you don't then cough it up, you've done nothing. And so just having it shake you is nothing. You actually have to do all the huffing and breathing techniques afterwards, which no one does, because the vest is shaking. I'm doing my work. With PEP, you can't fake it. You're sitting there with a plastic thing blowing into it, and you could watch TV, I guess, while you're doing it, but it's pretty hard. And every time you blow, it's stenting your airways and moving mucus up, and so it forces you to cough, basically. And so my eyes were open to this. I don't think you need a $20,000 vest to do good airway clearance. But again, I do have, of the 80 cystic fibrosis patients we follow, I have 2 that do use the vest, and that is what they like. But the smaller ones are much more portable, much more cheaper. And in one study, which everyone says there's issues, there's always some kind of methodologic issue with a study, why you can't believe it 100%. But in one study, it was superior. So the problem with these handheld devices is you need one of those old grizzled RTs that used to use them 20 years ago that knows how to teach you how to use them. Because if they just throw it to you in a box and don't show you how to use it, it is useless. And there's not a lot of new RTs that really know the intricacies of how to use these.
So I was going to say, Hallie uses the aerobica and the acapella. She has used both of those here locally, and our RTs have given them to us. But what we have found specifically with heterotaxy is you have a child recovering from a massive surgery, and the last thing you can do is be pounding on their chest or on their abdomen, anything that's affecting those. And so we have found those to be far more effective because they're not disrupting those surgical areas.
I agree.
And she's able to get a lot of that up. So they have been phenomenal for us.
The other thing is a lot of your children may have misshapen chest walls from all their surgeries, and to put a vest on, it's going to irritate and hit one area and not hit another area. So you can get them fitted all you want, but I mean, what I'm saying is, like, I'm going to be excommunicated here. Like, they're going to throw me out.
No.
But this is a big rift between Canada and the United States, and we've tried to prove this. That being said, every time I do this, I have someone that said, yeah, I went and asked for it, and they threw it at me and didn't show me how to use it. I'm like, well, then it's useless. You really need to be shown how to use it. The other nice thing is you can even do hypertonic saline in the PEP device and some of these others at the same time to say, so it's 20 minutes start to finish.
Yeah, I can say our hospital here locally does not even do the airway clearance if they can get away from it. So we are using the portable devices, and they have found it to be a lot more effective.
I think the same. And it's also for a teenager, when you're going to university, do you want to lug that vest with you? No, you'd rather have a little piece of plastic you can kind of hide and, do this when you need to. So
I agree. I say, are there any other questions? All right. Well, thank you so much, Dr. Shapiro.
Thank you.